I have to show up every single day to support the other community partners, because it's the only way we're going to try to provide true care to this community. It's the only way we're going to be an organization of excellence.
Even if there's continued use of a substance, we have to be able to hold that, and we have to be able to challenge a lot of preconceived notions and ideas about what providers are supposed to do.
Also, to show you how we hold hope that tomorrow we get to try again. I will open the door tomorrow and I'll greet you with the best, most gracious and humble smile I can and say I'm here to support you, regardless if that means I have both hands and feet tied behind my back. The behavioral health landscape splintered pretty significantly around that time. There were massive silos that were decades in the making of distrust amongst different community partners and different stakeholders. And it made for a very difficult time to create a sense of community, and again, I started in the industry in this community at the very moment that everything really blew up. And so I can't really speak to the historical facts, right? Like what it was like before that, but what I felt was a community in absolute dire straits that was not communicating and collaborating well and didn't see an opportunity in the near future for that to be something that can happen. But over the last 5 years, I've watched that change. And to your point, it's not just hope within the walls of the different organizations that I think has been fostered and pushed along, but it's the hope within the entire broader behavioral health landscape community that we will get to a better place. And we're starting to see it on a daily basis now.
And were you with MindSprings at the time, or were you with a different organization?
I was with MindSprings at the time.
Okay, got it.
I had just started.
And in what role? Clinical?
No, I was I guess you could call it, I was a case manager, but I was an employment specialist.
Okay.
So I was a case manager. So it's a bachelor's level position, providing support to individuals to resource different benefits programs.
Sure.
Right, is generally what the case manager does, but mine was more of a focus on employment services specifically. So I help people find and maintain employment. And it was an incredible role because it was a position that was created and supported by grant dollars through the Division of Vocational Rehabilitation.
Sure.
And so it had very specific, things about it, fidelity things like that I had to do. And one of those was I had to be community-based. So I was out in the community constantly. And I had to connect with employers, a certain amount of employers every week. I had to make new contacts.
Right.
So it was like I was thrust into, obviously I represented a part of the behavioral health landscape, but I went and contacted the larger, broader community that wasn't tied into that. And I got to create connections and see what was going on in that world, see how people felt about our organization, see how people felt about the general access to care for behavioral health and substance use services. I also got to learn a lot about how the general community felt about those things, where the pockets of stigma existed, and saw it as a really wonderful opportunity. Every day I was like, I get a chance to go out there and educate somebody on the industry. We get to go out there and educate somebody on what we're doing and how we're supporting individuals and what recovery looks like and what it means to have hope and all these other things. And it was a really beautiful job.
So you're doing that, as you just described, though, that like all this like press comes out around the fractures and siloed care and all that. So like, what was that experience like to have so much passion and hope and just kind of fire underneath of you to create the connection between, right, behavioral health and the larger community, and then like there's turmoil happening?
I enjoy those things.
That's probably why you're in leadership.
I enjoy the opportunity to face a problem and find the solution. And I believed wholeheartedly in what we were doing. I was very fortunate to have really great leaders in that organization, that is, it's different from what it is today, obviously.
Yeah.
And I'd love to talk about how it's different, but at that time, things were tough. A lot of leadership left, but who remained were the people who had a dedication to seeing this community have access to a community mental health organization that was of the highest quality that it deserves and dedicated to the work that it meant to get there. So, and I had a value in me of like, if we're in this industry to provide service to others, whatever that looks like, I have an obligation to everybody in this community, insofar as I am capable and insofar as my bandwidth is allows me to touch. But at the same time, I not only have an obligation to the individuals in the community, I also obligate myself to all other stakeholders in the industry, in this community. So regardless of where the state of the union is for our organization and the work we're having to do to recover and build and move towards a brighter future, I have to show up every single day to support the other community partners, because it's the only way we're going to provide true care to this community. It's the only way we're going to be an organization of excellence. It's not in competition, it's in collaboration. It's, there's 1,000 cheesy cliches, right? It takes a village, yada, yada, yada. But it's true. If we don't step up and support one another and hold each other up and show up over and over and over and over again for one another, this community is the one that suffers. So what I saw as, a system that was being burnt to the ground, and maybe it needed to be, was just a profound opportunity. It's, okay, it's burnt down, so what do we want it to look like? And that required action. That required showing up and doing it over and over and over and over and over and over again. And the role I was inhabiting at the time, I got to do that with the community directly. And I didn't focus so much on the industry. I focused more on providing, it was an opportunity to educate the general public on this is what it looks like for somebody to come and get care. And sometimes that conversation didn't include me telling them who I worked for, because there was so much stigma about what I was doing. That it was easier to gain rapport and trust with somebody and then start talking about the harder stuff that there was stigma around. And I saw a lot of change. It was a lot of fun. There was a lot of employers that I met with who were like, oh, I'd never hire somebody with an addiction. But by the time I got done talking with them, they were like, oh, who do you have that might be good for this role? And it's like, there it is.
For sure, because so many people out there, no matter what their belief is as it relates to substance use, to mental health, to just behavioral health in general, either A, have a connection to it. Like we know the stats, right? So like basically this stuff touches everybody in some way or another. But also when you frame things as like second chances, like do you believe in second chances, third chances, right? Like every human that we sit with has had failure, has had difficulty, has had challenge. And most people start to align to the idea of like, well, of course, because someone gave me a second chance. Someone believed in me when I didn't believe in myself, right? All that. And like using that sometimes as that way in, as you said, we don't have to lead with the chin in the ring. We can, hey, have this conversation a little bit. And then, we open the door to like, well, like this is what we have. Like we have an opportunity to get people back to work, to be productive members of this community, to add to, again, no matter where you stand on a political spectrum, add to tax base, not taking resources, right? Like you can frame these conversations, knowing the room that you're in, right? To be able to connect with community members in all types of different ways, which I think is a lot of the fascinating work around the advocacy and the community work that you're talking about. Is it's that like combination of like tact and strategy around like, how am I going to connect with this person as an individual or as an organization, and then kind of find my way in. And it doesn't mean, of course, that every door always opens, because we both know that there's still going to be people that have very closed minds. Sometimes it might take years, sometimes it might take decades, and that's okay. But I really appreciate you like just talking through that approach. It sounds like that was incredibly meaningful work amongst like everything that was going on. And then back to providing hope to a community. Hey, you can read this in the newspaper, but at the end of the day, like we're out there doing the work, serving, right, providing hope to the community, which is huge.
Yeah. And, Mind Springs at the time had such a bad rap, and there was a lot of things that needed to change and have changed in a significant and drastic way. To become who we are today as Health Solutions West, which we are an incredibly high quality provider of services in this community today. We are in a thriving model. But at that time, that was not the image in the community. And I got to go out and meet the people in the community. And like I said, from an employee position, but I got to see how people really felt. Where were they at? And there wasn't a lot of hope for what was capable, for what was possible. And then as my role changed and I got to step into leadership a little bit and start to oversee some community-based programs, which required me to go out and start not meeting with employers now, but meeting with the other stakeholders in the behavioral health landscape and hearing again the dismay and the frustration and the decades-long difficulties in the relationship that had caused some fracturing in the trust in the system, and it's a significant fracturing in the hope that we can figure it out. But no matter what, and our CEO, Jason, when he first came to this community and started meeting with the different stakeholders himself, this is one of the first things he said was, he was blown away by the amount of hope in the community that all up and down the Western Slope, that we can do this, and that they need us to be what we're capable of being.
Right. Well, it's so easy to become the lightning rod, right? As you describe, and so when you are kind of the central hub, right, then anything that occurs, right, just becomes the lightning rod for criticism and for blame and all of these things. And it's not to say, as you mentioned, that like we can't do things more effectively. We can't be better partners, right? Like there's always ways that organizationally we can look at improving, but when you become kind of the community-based provider, especially providing the services to the under-resourced, to the underserved, to most of the folks that if you weren't around, they wouldn't be able to get any help anywhere else. It's then becomes so easy to just go, well, see, it's like, it's their fault. See what they're doing. Right. And it's been my first kind of introduction into communities like that. Like most of my career, I worked in like larger metropolitan cities. So San Diego for much of my career, Northern Virginia and Washington, D.C. I know we've got like a little bit of the Virginia connection. And in those communities, right, they're so resourced. So you've got community providers, but you have 20 community providers, right, in a city. Then you have all the different folks that take commercial insurance and right, like the access to services. I'm not saying they've met the goal, because of course we can look and say like, not sure the goal is really being met anywhere in the US, no matter where you are.
Right.
But like if you wanted resources, like you not only had options, but you had a lot of different resources available, right? And then to come into this community 2 years ago and similar to just start spending time with stakeholders and kind of learning, it's like, boy, like community, not only here locally in Mesa County, but then even the larger Western Slope, just kind of like pointing a finger at a single organization. Like that's really hard to be the one that is attempting to hold that position within a community without. And it's not to say, like you said, that there aren't amazing people and other collaborators and stakeholders and organizations, because there is. But again, just like the size of health solutions versus the little mom and pops around and things like that, it's so easy to then kind of become that lightning rod to just be like, well, like we're just going to blame everything we possibly can on that organization. And like that has to just be insanely difficult to deal with.
It is, but I want to be careful in my own way of talking about it. And I think an important way that we talk about it in general is there is never an absconding of responsibility.
Sure.
When you put yourself in that position, you obligate yourself to the community.
Of course.
Right? Like being the lightning rod, okay.
And like we chose.
Hit me with it.
Yeah.
Tell me where I can do better. There's going to be failures in the system. We're going to drop the ball. There's going to be holes in the safety net. And that's one of the things that I am most proud of in my role, is that I get to be a part of a big focus of mine is trying to find the holes in the safety net and close them up more and more and more and more and more. But the thing that I've learned with holding hope is the guarantee that tomorrow I'm going to find another hole.
Yeah. And you know a little bit about even what's been going on with us, and just, the system is the system. We have chosen to work within, right? So you talk about the holes, and we not only talk about the holes like, internally, and as I was mentioning, day 2 of being open yesterday. And
Right.
of course, there's patients in front of you, and right, all the technology's not working how it should.
Right.
And right, so there's all like the internal holes of everybody like, oh my gosh, like
Right.
this was great in practice, but now it's not working. But then generally, when we look like globally and talk about like funding, right? And funding dries up and payers put pauses on new contracts, and right. And then you're just constantly having to shift and adapt to the things that are very much out of our control, right? Like I don't have control over whether a payer decides they want to contract right now or put a pause on that.
Right.
I have to be like a steward, right? And like a calm amongst the storm,
right?
To say like, this is the long game. And so what do we need to do in the short term to ensure sustainability, and how do we serve, and how do we create access, and all of that? And so when you mention that, it is right. Like we're within the confines of federal government, state government, municipalities, right? All of this. And then as providers, like constantly having to go, all right, like
right,
kind of doing it with a smile, because otherwise it could get a little overwhelming when you go, okay, we were planning on this for, years, and all of a sudden, like, that's not happening. All right, like, how do we have to shift so that we can continue to carry on the promise that we have to the community, to partners, to community? It's that ability to adapt in leadership is what's so critical, because we are at the mercy so often of the larger system, because we're not just working with private pay and out-of-network payers.
Right.
So again, that's the choice that you make to get in that game. So then to your point, we make that choice to say, yes, like we are responsible, and we made these commitments, and now we have to figure them out.
Yeah.
And there's going to be a lot of bumps along the way.
Yeah.
There's no other way to go about it. So
right.
How do we help normalize that and just kind of open those conversations becomes so critical.
Right. It said a bit like you said earlier, like, or we were talking earlier about how do we get admissions level staff, right? How do we give them the tools and the skill sets and the ability to take care of themselves right at that front door, so that when somebody's coming in with expectations of what they can get and how they're, what success is going to look like in treatment for their family member, for themselves, and whatever that is that how do we extend grace and humility and confidence over and over and over and over and over again, regardless of what email we just got, right? And that's something that I think, kind of we're thinking about in the larger part of this conversation is like within the industry, how do we create space and visibility for everybody else to look into the black box of this industry and understand the kind of pressures that we face, not to make excuses for our failures, but to help. I think the way that the message is intended to come out for me is to go, this is what we face, but this is also to show you how we hold hope that tomorrow we get to try again, and we get to try again, and we get to try again, and we get to try again. And regardless of what the federal government says, regardless of what comes down from the state and budget cuts and pauses on contracts, I will open the door tomorrow and I will greet you with the best, most gracious and humble smile I can and say, I'm here to support you, regardless if that means I have both hands and feet tied behind my back, which is so often the things that we face in this industry, especially at the level of care that our organizations provide our community.
Yeah.
We're in community mental health. That is one of the least resourced sectors of the health, the entire health landscape of our society.
Absolutely. I had said to a buddy of mine who has done community integration and rehabilitation within communities, really in the Northeast, for 25 years. And he now does it on a private basis. So again, totally different, right? Came up in community mental health and did PACT work and all of that. And that basically as a company, and they do PACT work, but it's private. So they've built, high-end doctors and high-end nurses and high-end clinicians and all of that again do the work in the community, but it's paid for by folks that have resources. And I was sitting with him and I said, talk to me about, taking the best of like what private pay care does, and then how do we do that at a community level, right? And he smiled at me and he laughed, and he said, he's a bit of a historian and he's a sociologist by training as well. And he said, Chris, they figured this out back in the 1960s. And I was like, well, what are you talking about? And he said, go look into like JFK's last bill that he wrote in prior to his assassination. And it was this idea to take care out of the hospital, put it into the community, right? No wrong door, right? Create the opportunity for people to walk in, community outreach, like basically like so much of what you guys do and what we're obviously kind of trying to come in and do as well. And he's like, that's not a new idea. He said, so what they did was they funded the infrastructure, but what never happened was they never figured out how to fund the sustainability. So they were willing to be like, hey, we'll give you the money to build the hospital and to build the facility and to do this, but really like they were never able to kind of come behind it and create the pathways of funding that would really support that staying. And he said, and then the more that I read into it was that's what then began to create the fractures in the siloed care, because then everyone was kind of trying to go after like individual pots of money instead of communities going after money and kind of building and sustaining the infrastructure. And I was like, it's so fascinating now to think about that a lot of the work that I know we're trying to do, the more I get to know you guys, I think you're trying to do is actually going back to a lot of these things. Like these are not new ideas.
Right.
Like, these are like meet people where they are in the community, serve them here, don't ship them away, right? Like this is their home, bring them in, create the relationship, long standing. Even you were sharing a story earlier, even if that story takes years to work with an individual who is stumbling and finds hope and stumbles back and finds hope, and to have that built and to have that infrastructure, right? And then and so now it's like the creative minds going, okay, like not a real new idea. However, how do we sustain, right? So how do we create the relationships and the partnerships and the collaborations and the funding and all of this when funding's getting cut and all of this, and we're having to constantly shift gears to figure out, all right, well, that's not getting paid for anymore. How are we going to keep doing this because we know that it's so necessary to the community? So it's been really interesting just to dive more into the history for me around like these ideas that you guys have been doing for quite a while. They're not really new. They're not really that innovative.
No.
It's just, how do we create sustainability within this so that there is the regional infrastructure so that people don't have to go back over to the Front Range or to Utah or whatever it is. Like we have the community infrastructure here and the sustainability here. And then it comes to like also like how do we work on funding, right? Like it's a whole different thing of there are pots of money. How do we come together? Right? In those dialogues, how do we look at that? And so anyways, I don't even kind of know where I was going with all that, but it just continues to be like a really interesting dialogue around like the sustainability piece and, you know, rates getting cut and Medicaid getting cut. And there's also folks that aren't Medicaid eligible and safety nets, and right, the FQHCs are going to be in some pretty hot water pretty quickly with everything that's going on at the Fed. And it's like we're sitting here kind of watching the storm, just like, okay, well, we got to show up and do work today.
Right.
I mean,
what's next? Yeah. There was a period, so I have so many thoughts on that. And I think what you're saying gives great direction, but there's so many ways to go, right? Like, I think the underlying foundation of this conversation was, again, to create some visibility in the black box of the industry. That's it. But it's so hard to articulate. Like, yes, there is an incredibly complex system of factors that impact our ability to provide the care that we have obligated ourselves and promised ourselves to do to this community, to any of the communities we serve. And I think where I always come back to is, how does the community feel about it? What do they prioritize? Mesa County, I've seen it change in a positive way. How county officials and city officials look at behavioral health and how they involve themselves in the conversation. I've seen stigma break down. I've seen the language change, which is incredibly positive to see. But without a community that prizes and prioritizes this, and I'm not saying that anybody's failing by prioritizing something else, right? This is my world. This is what I prioritize.
Sure.
But the higher we can get this up on the list, the better access to care our community will have. That's all there is to it in my mind. And that brings us back to the hope part. How do we create hope in the community that what we say we're going to do, we can do, but we have to have your support? And if I didn't have hope in something being able to achieve that, I wouldn't support it either. And so I think it comes down to a bit of that. And I'm sure it's far more complex than that, but it is a bit of that. And to your point, maybe to bolster some of the hope that I'm hoping the community can gain from this conversation is when we talk about, I'm going to go down a rabbit hole here a little bit. I'm going to try not to go too far. It's around case management. So explaining a little bit more of what case management means. It's professionals in the organization who are not clinical in nature, meaning they do not provide therapeutic interventions. They're not going to come in and use cognitive behavioral therapy or dialectical behavioral therapy or EMDR, right? Whatever buzzword modality you want to throw out there. They're not going to do that. What they're going to do is they're going to sit with the individual. They're going to meet them where they're at. They're going to get to understand the different factors that are impacting that person's ability to achieve a stable and meaningful life. So that might mean I sit down with you as a case manager and I get to know you, Chris, and I find out oh, okay, so you have low-income housing, but your minimum wage job, you're struggling to pay the bills. Last winter, you couldn't even turn the heat on because you didn't have enough money to pay for that. You had to choose between paying for meals for your 2-year-old son or turning the heat on and being able to pay rent. And so you chose, I can't turn the heat on, so you bought a couple extra blankets. And then I learned that there's complex family issues that are playing a role in how you're able to achieve stability. I learned that maybe there's some skill sets around job and maintenance of your job that make it difficult. There's transportation issues and daycare issues. And so we can't even, maybe you're struggling with alcoholism and that came about as a means of coping with the stress of life. But you're doing it, you're making it, and you're showing up every single day and waking up, getting out of bed and doing the best you can. We can't begin possibly to treat that alcohol use disorder until we achieve a level of stability in what's called the social determinants of health. So transportation, housing, food, basic needs. Until we can take care of that, treatment's not really going to be that effective for most people, right? Because we're having to use known coping skills, which may be maladaptive, but they work.
Yeah.
And so if we can achieve stability, maybe we can start to get some other options for coping skills and move towards recovery. And that's what our case managers do. They assess for those things and they help to navigate the different resources in town to support them, whether those are private industry resources or those are community resources or those are state supported benefits or federally supported benefits programs or county supported benefits programs. Now, there's historically not been a very large amount of case management resources available in this community, but we also have one of the highest per capita rates of any county in the United States of homelessness. There was an incredibly large and still quite a large gap can't find the word I'm looking for here, but just gap between what's needed and what's there. And there was a program started up a couple years ago that the county led and supported to develop more infrastructure around case management services in the community. It was purely focused on one specific population, and those were high utilizers of emergency services and high utilizers high rates of recidivism into incarceration. And so those are the population focus. So our most vulnerable populations in this community, people who struggle to engage in care on their own, or maybe have tried and it didn't work out, or maybe didn't even have trust in the system in the first place and never did, or they're living with such significant mental health conditions that their ability to effectively engage in care is near impossible on their own. And so they utilize these other services as a means of getting their needs met. And they're stuck in this cycle of homelessness and incarceration and emergency services. And so the lens that approached it with was, let's get some dollars, and let's get a couple organizations to hire some peers and case managers, and let's put those people on the street. Let's get them out into the communities. Let's get them into the homeless encampments. Let's send them under bridges. Let's send them out into the woods to find people, connect with them, and engage them in care. And this large referral network of different agencies and organizations were included in that. And it lasted for a couple of years, and it required a good amount of grant dollars to the tunes of hundreds of thousands of dollars were put in this. And it was, unfortunately, the county didn't do a good job of gathering data by their own words, not by mine. And I don't know what the barriers were to that. So, the success we can speak of is anecdotal, but I ran one of those programs for our organization, and we saw an incredibly high level of success with it. We saw a lot of people leave some of the most dire of situations and enter society. And I mean, like, literally, that's it. Like, we took them out of the desert and got them into society. So these people living out in the desert at the end of 29 Road who would never, ever engage in care, or there's a handful of them today that are active members and productive members of society, and very much more better off and more stable. And there's still a long ways to go for them, but that's what we're able to achieve. Now, the main thing of this long diatribe is to say that we held a meeting with community partners the other day. So that program went away because it lost funding, but it lasted long enough for an infrastructure to get built. And a couple of those organizations maintained the effort, but had to change the model, mine as well. So that team is now flipped, but they're still doing the same work. Would not have been possible 3 years ago. Today it is. We figured out how to do it. We figured out how to make it sustainable. We figured out how to keep ourselves in that high level of community action with our case management team to bring people out of the desert and get them into society, or take people out from under a bridge and get them into care. Now, we held a community meeting for partners who refer into that program, and we sat down with the city's co-response team, who shows up over and over and over again, because those are the folks who are usually the front lines with most of these individuals in our community. And they said that they were blown away by what is being achieved today, because they were there 5 years ago. And they said 5 years ago, we could have bumped into some so-and-so on the street who needed the level of support they can get today, and we would have known that there was only one case manager in this community we can call. One person. Again, one of the largest rates of homelessness per capita.
Right.
And there was one case manager they knew they could call. It was an impossible mission. And she's like, today, we know 5 different organizations. Enormous amounts of staff and resources. We're never worried that we can call. We can call one place. If they're not picking up the phone because they're busy or they don't have anybody available, we can call the next place. We can call the next place. We call the next place. They said it's more rare today that they can't get somebody to show up and to go and meet that person in the moment in a state of emergency and connect with, de-escalate the crisis and get them into care and start working with them long term. It's more rare for them to not find somebody for them to work with than it is for them to find somebody for them to work with. And that speaks exactly and directly to what you're talking about. Where this 60 years ago, JFK saw a vision, and today we're still struggling to figure it out, but it is possible. There's hope in that.
Of course. Yeah, I mean, similar to what you said before you went on that, where you said, oh, there's so much in there. That's how I feel right now. A couple things that stick out to me is starting with social determinants of health, right?
Mm-hmm.
Like, my partners and I have talked for years about the idea that if somebody walks in the door and they're worried about their cat, you can't do meaningful therapeutic work.
Right.
You need to go shift gears and figure out how they're going to feel safe that their cat is taken care of. Right. Like at really simple levels. And so it's that shift in expectations as well, not only organizationally, because for us, we see that, but externally, right? It's like, yeah, we're not going to get in and do deep somatic or EMDR trauma-focused work when the person can't turn the heat on and they're worried about their dog and they're worried about how their kid is going to eat, like that is the priority. Right. And even if there's continued use of a substance, even if there's continued recurrence of whatever the thing is somebody's walking in our door with, we have to be able to hold that. And we have to be able to challenge a lot of preconceived notions and ideas about what providers are supposed to do. I was saying the other day, right, to our entire team now, this is the substance use disorder is the only disorder I'm familiar with where the expectation of many providers is that in order to receive care, they must be asymptomatic.
Right.
Right? Like, no, right? Now we have to maintain safety and milieu environments and all of these things, right? But like, just because somebody has a recurrence of the thing that they're coming for us to help them with, that just means there's a recurrence of that. Like, that is it, right? Like, that there are not consequences. Like, those are like old beliefs, right? And so we're challenging that as well as we start to shift the idea down to social determinants of health, identifying like baseline stability. Like, someone is not going to be able to start addressing these other things that we or the community or anybody else might say, that's what needs to be addressed. And it's like, well, we can't do that work until we help this person actually figure out how to get to us. Right. We are, right. I mean, Grand Junction is it's a large community, but there's still a lot of rural communities that are in and around this area. How does someone get here? What about someone that walks in and doesn't have an email, doesn't have a phone, can't call in, can't set an appointment, right? Like, we're having to look at all these factors on that case management side, which is so critical to being able to do longer term work to helping people address chaotic family systems and childhood and how they grew up and how they've created adaptation to manage how they are okay in the world, right? That the use of a substance is merely a solution to their problem. It's not really the problem. But then if I shift gears, you talked about like doing the really hard work that most people don't want to pay for, right? So like, if the foundation of our work is like, we have to figure out how to create stability in housing, stability in food, stability in your family, stability in your kids, right? Like, all of that, that is not the like sexy work that payers want to pay for and funding wants to come out for and all of that. And so that then becomes like such an interesting component. And I can speak from my lens, as you mentioned, right? I see the world as I am, not always how it is, but from a leadership perspective is to say, how do we shift resources into these areas where we actually might lose money in the business, which is also just a very realistic part of running an operation. Is some parts of the business actually help create sustainability, some lose money, but we know we have to do these certain things, transportation, for example, right? And so it's like, how do we as a community and individually, of course, but to look at like, okay, like, how do we shift resources really into serving what the major needs are when someone walks through our door, and then getting them to a place, and that's an ideal world that everything goes, in just this beautiful straight line, which it never does. There's always a roller coaster ride, but that focus of ours to be able to go, okay, like, so much of the meaningful work is here at a base level. We can't really do much beyond that until we get that addressed. But also, I think that a lot of people think, well, the solution to the unhoused is housing. It's not. Like, it's a part of it. But it's actually it's all the case management work that somebody, even when they say, I don't want to be living the way that I am, there is a large gap between that and housing. And what we see is, even when you take somebody that says, I don't want to live this way anymore, I don't want to be in the desert anymore, I don't want to be operating this way, putting someone in a house doesn't solve the issue. So then as a community, how are we helping to normalize the conversation, as you mentioned, not only with stakeholders, with just community members, right? That like, the numbers that a few folks in this community have said to me is that probably about 7 out of 8 folks really don't want to be living that way.
Mm-hmm.
Because I asked, I'm not an expert in the unhoused. So I asked, and they said 7, 8 out of 10 don't want to be living that way. Sometimes hope really hurts. They've tried before, whatever it is.
Right.
But the gap is the exact same gap that you're talking about, which is we've got to do so much to get them to a place where that's going to be sustainable long term, whether or not they have substance use or mental health. Because not everybody that is unhoused is struggling with substance use and mental health, which is, again, a thing just to normalize for folks out there that not everybody on the street is struggling with a mental illness or an addiction. And so that, like, it's the hard work. It's that frontline trenches type of work of like, we've got to find the resources. We've got to find the funds. We have to figure out how to not only create hope and keep somebody engaged, but keep it and get them connected into the next thing, which builds a little more hope that, oh, they can turn the heat on now. Wow. Like, and a lot of times, like, I think that as communities, we overlook, right, that sometimes very long, drawn out process that payers don't pay for.
Right.
Let's get real. I mean, they do. Like, they will reimburse for case management, but it's very low.
Right. And it's gotten harder.
Yeah, correct. But like that in a community setting, when we're talking about like this community coming together, right, providing all these organizations now doing case management, it's not like there's a lot of people being like, oh yeah, let's toss money at that, right? It's actually they're pulling back in some of the most important areas, which then we have to continue to get really creative of like, we know this is how we have to show up. So how do we do it? And again, collaboration, right? Like you speak to that like so eloquently, like the ability to be in the same room with people and say, hey, we've got smart minds and we've got creativity. So how do we come together to really look at that need?
Yeah. And that's fun because it gives me an opportunity to talk about something cool that's coming up. It's been done a couple times in our community, but and this is another signal. This is another signal of the larger behavioral health landscape and how it is unsiloing, continuing to unsilo, because I truly believe that it's significantly unsiloed today. You have really strong communication, collaboration across different organizations and agencies. And I mean, I couldn't speak to this with any knowledge, so I'll just repeat something that somebody else told me who is from the Denver area and I know it's complicated. It's not just straightforward like this, but we have a behavioral health steering committee, which is just a bunch of behavioral health organizations and people from all over the behavioral health landscape come together once a month, give up their own time to sit down and talk about the issues and discuss as a larger community which direction we need to be going in order to better serve the community as a whole. And there was at one point, it was like 40 something people were showing up like that. And maybe the number was larger, but somebody who had just come from the Denver area and been to similar meetings like that in Denver area, they were like, we obviously have a much smaller population, but they said that we had a much greater size or much greater volume of people showing up to these steering committees, even with a much smaller population. That's how important it is in this community. That's how dedicated this community behavioral health providers is to creating collaboration and communication. And one of the things that we've seen work a couple times, 2 different iterations of this, is something called like a complex case review. And it's just a group of providers and agencies that come together and have a shared agreement to share knowledge. And there's a lot of legal liability that gets covered in this, and we won't go down the rabbit hole of that right now. But it's a significantly hard thing to develop because of the liability involved with it, and because of the risk that goes into bringing a bunch of people from all over the community to talk about somebody and to provide care. But when it has been done in the past, it was done very well and had really strong success. And I'm getting to start one up now. Our organization is taking on the liability of developing this, a complex case review. And we're going to, again, and going out of the community, this is a thing that everybody kept asking for. When can we have this back? How can we have this back? How can we do this again? So we're going to try it a third time. Hopefully the third time's a charm. But it's an amazing thing because it will bring together people from different parts of the behavioral health landscape and we can look at an individual in our community who has agreed to be talked about, right? Let's be clear, like it's not just us picking somebody and talking about him doing work
Sure.
and starting to do things that step on their autonomy and, forget their dignity in their own life. This is something this person's agreed to be a part of. But it will include stakeholders who can provide support to individuals that are uninsured and underinsured. It'll include organizations and agencies who can come to the table and go, oh, this person doesn't have them, because that's a thing that you pointed out, like case management. It's getting harder and harder to provide case management services because we're getting less and less money to do it. And the only payer that's going to allow us to do it, allow local community providers to do case management, is Medicaid.
Yep.
That's it. And they're pulling back some of the funding. They're making it more difficult to do, right? Because of their obligations to the federal government and cutbacks around Medicaid. And so we have to work within that system. The thing that a lot of people don't understand is that in order for us to build case management, be able to provide case management services to an individual, like you said, they have to have a behavioral health or mental health or a substance use disorder that is diagnosable. Because that's the way our world works, is that we have to have a diagnosis for insurance to say, okay, I'll pay for you to do that. There are a significant amount of people living out there struggling with social determinants of health who can use case management to a very positive effect to change their lives and move forward, who do not have a diagnosable disorder. There's this whole swath of the people, of our most vulnerable out there, who do not have access to help and support and the care that they need because they don't have a diagnosis. And that's brutal. And yet we are asked to show up and figure it out, and we will keep looking for a way to do that.
That's where the creativity really comes in. First off, I'm really excited to hear about the complex, just the case consultation. I can't remember the exact term, but I hear case consultation, and I'd be excited if we were extended an invite, not for me, but for a licensed clinical professional that works here to.
Yeah. I do intend to. We're in the early stages of reaching out and networking with the different stakeholders. You're on the list to come to.
Yeah, just to put you on the spot.
Yeah.
To me, one of the things I've spent so much time in is creatively being able to source funds and collaboration, and how can you take funds in an ethical and transparent way and be able then to work within this community to serve the needs. And so it's now happened twice where I've been able to negotiate grants. So as you know, grants come down. Here's what the grant's for. Here's the population, all of this. Twice now, I've been able to work with stakeholders and say, again, join with them. So we were trying with clients. We know the goal that you're trying to achieve, right? And aligning and saying, but what if we looked at it this way, right? And what if we realized that housing is not the answer, but housing plus services is the answer? Housing plus case management, housing plus med management, housing plus this. And although sometimes initially there's kind of deer in the headlights look, by that maybe second or third time of having that conversation, folks start to go, that makes total sense. And I go, yeah, and we'll be able to have data because we have those systems set up. So we'll be able to show the kind of return on this, right? And what it's done is it's opened my eyes to go. So for folks that may need to utilize case management services and things like that, but may not fit into a diagnosis order, right? It's like, how can we start to have those conversations as a community? So for me, it's just me. Half the time I have 10 ideas, 9 of them aren't any good and won't really work. That's why we have good operators and partners who do know how to make things executable. But it's also where I start to think longer term about, right, profit margins. Look, over a certain amount, right, even if you maintain, right, you've got to take that money and reinvest it. Like our CFO always says, like if he was to take a look at a company that had over 20-ish% margins, he'd say like they're not really probably investing enough back into the community, the staff, the culture, the clients, all of this. So it's like, even if we start to look at, hey, like how do we even potentially take some profits that we make and come together with other providers and say, like, that's a gap. But if we started to pool a little bit and pilot a little bit, and then we get a little data behind it, a little evidence behind it, could we then go and have some conversations with folks that we're not just like asking for cash? Like we kind of put our own, like our reps on the line, a little bit of our own money on the line. We piloted something, which again, I'm sure that getting to know you guys more, you've probably done this over the years in a lot of different ways, but it's like, cool. Now, maybe we have a little bit of data on working with folks that aren't going to hit criteria for a substance use or a mental health disorder and be able to, you know, receive payment and reimbursement from a payer. But we've seen this really work. We can track kind of the economic impact. We can track the impact within the community itself. Now, could we go collectively to a source of funding and say, hey, like, do you want to continue this? And like, here's all the benefits to it, you know? So this is where my mind like goes often is like, we know the system we're in. And we know we've got to adapt within it, but are there other ways that we can also start to think of how do we start pooling resources, whether that's capital, whether that's people, whether it's time, right? Like there's a lot of ways that, that we can give, and can we start to address those things too? So anyways, I often have to pull back because I have a very strong kind of moral ambition around injustice, and I can get caught up in, you know, the unhoused conversation, even though that is not an area of expertise of mine, nor do I know the answers or the solutions, nor do I have the answers or solutions to the work we even do here. But it's when you talk about like the folks that come together monthly and the collaborations, it's also like, man, like there is so much opportunity, and there are so many people that are willing to give in whatever way they can. And then now really as like Ava Health, Health Solutions West, right, being two of the larger organizations, really not only in Grand Junction, but the Western Slope at this point, how do we start to come together? I mean, have those dialogues too about, it may not be something we can do now, maybe something we're looking at in 2027 or 2028, but like there's so many opportunities to serve. And like that's what continues to keep me fired up to walk in the door every day is like you mentioned, it's like there's a problem and I see that as a challenge, and then there's also like opportunity there. And how can we also level up to then be able to put data behind it? Right. So we're not just telling the story, but now we're backing it up with data, and then being able to really have, you know, solid arguments as to why like these types of things should be funded. Stuff I get really excited about is like the world that you're leading very much in Mesa County and being a part of that. Are these creative solutions, right? Like maybe case management won't get funded, but I know like when there's a will, there's a way. And there's that Margaret Mead quote that I love, which is, I always butcher it, but something to the effect of like, never doubt that a small group of concerned citizens can change the world. In fact, it is the only thing that ever has, right? And you speak to that, like I resonate a bit with what you've talked about in the community here. And that quote really resonates with me.
It's so I gotta say, like, it's so incredibly exciting to see Ava Health open its doors. Right, you guys are coming in and filling gaps in care because the need is so great in this community, and I think that is lost on so many people. How huge the need is. No one organization can take care of it, and you know, not saying Health Solutions is the only organization in this town. Right, there's a wide variety of behavioral health providers in this town who are providing similar services at different levels and filling different gaps. And what you've been able to do coming into this community is bring in the resources necessary to fill some of the larger gaps, the housing, and an ability to provide a type of care that is more aligned with integrated care. Right, like you're talking about. Let's give them housing. Let's also give them a case manager and a peer. Right. And let's attend to their medical needs and all these other things. That's how we make progress. And we can't do that. We don't have the resources to do that. You guys do. And that's how collaboration has to exist. It's looking at each other and going, who's best going to serve this person? Who's best going to be able to take care of them? And do we split the resourcing? And how do we come together and have an open dialogue that supports that?
Which that's like, again, I love to like push boundaries, you know, like I'm just not familiar with like, especially organizations that are receiving funding through certain like sources at some point, like just coming together and even talking about it,
Yeah.
and like not being worried, right? And I remember I wrote a letter for somebody locally, for an organization locally. They were going after some opioid dollars, and they were like, a little bit like, hey, would you? And I was like, absolutely. Like, when do you need it? And she's like, this afternoon. I'm like, fantastic. I wrote a beautiful letter about like the respect we have and like the services they're going to bring and how they're going to, again, service a gap here and all of that. And it's like, I'm not worried about like where you're getting funding from, right? Like it's our job as an organization to do that. But it would be interesting at some point to be like, all right, like there's a pot of money. Like, do we want to think about how as a community you come together around that?
Right.
And I know that there's been so much, again, another topic for another day, but like just scarcity around it. And like, I know we can do it, but when you speak to it, whether Ava and Health Solutions West operate at like the highest levels of efficiency and performance and expectations and service to the community and all of that, I mean, we're talking about like capacity that is so under what the community actually needs. Right? Like, I don't know what your like bed count is across all levels of care, but if you combine that with ours, like I guarantee we're under 150 beds.
Right.
When we look statistically at people that are struggling in the population here, and we run those numbers, like we're thousands
probably
of staff members, thousands of beds, right? Under like in a place of saying like, we can't even do that. Right. So like, it's never going to be about me and you,
right,
us and you guys. It's going to be about how do we do that, but also then continue to bring up the next generation of folks. And I say that now being 41 and like feeling like, oh yeah, there's going to be some young cats coming in, feeling how I felt early in my career and wanting to make change. And not only like the mentorship and the guidance there, but also as a community coming together and going, look, like you're passionate about that and you have expertise in that. Like, let's help you get funded so that you can raise that up. And then like, now we have an opportunity to refer in and keep you full because we're just going to get full a lot, between us. And so it's like, how do we continue to create the regional infrastructure to be able to really provide that, but also in a sustainable way.
Right. And creating that brain trust. Yeah. That institutional knowledge, creating an open door for somebody to come in and go, how did you do this? And be like, well, this is how I did it. This is how we did it. This is what we're doing today.
Yeah.
And giving that knowledge, like, please go do it and figure out how to make it work and find the gap that I haven't been able to solve and solve it. And whatever you need, you're going to get it from me. And that's been one of the most remarkable things. Like, my career so far is focused primarily on care coordination and case management. And the opportunities that I have had to sit with the different organizations in this town who figured out how to develop sustainable case management programs that serve and continue to do amazing work, and sit down in the room with them and talk through difficult problems to solve and have access to their institutional knowledge and their historic knowledge has been key for creating the programs that I've been able to be a part of that have shown success. And that's the only way forward, is we continue to show up and talk through and see one another not just at this table, but across the behavioral health landscape, not as competitors, but as collaborators. We're all here. The only competition in this community any one of us should ever see is the fight against substance use and mental health. That's it.
That's a beautiful way to close this thing out. You and I, now having done this, I can imagine we could sit here for many hours and many days going into all of this. Yeah. I just want to first off say thank you.
Of course.
I think that my goal in this hopefully is accomplished today, and that we are out front and center, right? Not just behind closed doors, sharing a nice cup of coffee together and saying, oh yeah, no, Chase and I sat down, but actually like getting in and being able to show like these two organizations are coming together. Like, we're in open dialogue. We're continuing to do what we can in collaboration with the incredible human beings and organizations in Mesa County to serve the need. And I think that we'll probably look to do this like on a somewhat regular basis.
I love that.
It's just been really fun, honestly, just to get to know you better and just to see how you think about things. And it's always amazing when you open the doors in the dialogue and you don't build walls, but you build bridges, is that like we start to see how aligned that we are philosophically and the way that we want to care for people and one another. So thank you for coming in, giving your time.
Yeah.
It's awesome to have you here. another episode of Inside Ava Health. Chase Wheaton.
Yeah.
Health Solutions West. We'll have Health Solutions West information all in the show notes, Chase's information. So if you guys are curious, want to connect with Chase or Health Solutions, go ahead and check them out and like, comment, subscribe, and we'll see you next time.